What's going on, everybody? What you're about to watch is a video cast that I recorded with Dr. Ryan DeBell, and he runs a company called The Movement Fix. Basically, he works with his clients in a very similar way that I do, where he addresses their common dysfunctions to optimize their performance. So, I hope you like it. Ryan, what's going on, man?
How you doing?
Doing well. Hey, thanks for being on today. But I want to quickly introduce you to the people watching this video so that they know who you are.
Sure.
Everybody, this is Dr. Ryan DeBell. He runs a business that he calls the Movement Clinic. He has a tangible office, which is called the Movement Fix Clinic, and he also runs a blog called the Movement Fix Blog, as well as giving workshops. So this year alone, he's going to be teaching over 30 plus workshops. I assume those are in the U.S., right, Ryan?
Some are in Canada,
okay.
if I can get in.
Got it. All right. So he's a fellow myofascist like me. He teaches these movement fix workshops. He graduated from the University of Washington with a business degree, and then from there, he went to the University of Western States, where he earned a master's degree in sports and exercise science, and then from there, he earned his doctorate's degree in chiropractic. So, Ryan, I kind of want you to give everybody your rundown, your background, and how you got to be where you are now in doing what you are doing now.
Sure. So as you said, I went to business school, and I quickly learned that the job that was going to lead me to wasn't what I wanted to do. So, like my senior year of college, changed my mind right at the end of college, and then decided to go into healthcare. And with some previous experiences that I had a chiropractor that really helped me out. So I was like, I'll go down that path. And so I moved down to Portland. I live in Seattle, so I moved down to Portland. That was the closest school. Went to Western States, and so I went through that whole program. And then when I graduated, the decision came up: do I start my own clinic, or do I go work at somebody else's clinic? And fortunately enough, my wife is a nurse, so she had a steady income, so I could take the kind of risk of starting my own business right off the bat. Wouldn't have been able to do it without her. So thank you. And at that point, so I started my clinic, and it actually was called something else. So it had a different name, and over the ensuing months, it developed into the Movement Fix. The way I got started with the workshops was I have a long history of involvement in CrossFit. So I started doing CrossFit myself in 2007. And so I've been doing it a little while. And to market my clinic originally, I put together like a 2-hour little workshop that I did for free at CrossFit gyms around my area. And the first one that I did, the gym owner he's been doing CrossFit about 10 years. So, he has a lot of experience too. He said, "Hey, Ryan, you should make this into a thing, make it into an actual thing." And I'm like, I've never even thought about that. And the next one I did, another coach said the same thing. She said, "Hey, you should put together a full day one for coaches to learn things that you think would be helpful for them." And I'm like, okay. And so she's like, "We'll host it at our gym." So we this was before my practice even opened. So before I even opened my physical location, I was doing these. And so we did one at that gal's gym. We sold it out a month in advance. I was like, hey, maybe there's something to this, And so at that point, I kind of just tried to, do a couple more here and there. And then I wrote that article last January. So January of 2014, The Best Kept Secret: Why People Have to Squat Differently, which got enormous traffic. And then I got a bunch of invitations from CrossFit gyms all around the country. So that's kind of where it really took off in that regard. But, the biggest thing that really kind of sped things up was just making content.
Yes.
Making content consistently is really the key.
Yep, getting yourself out there.
Yeah, exactly.
Coming to that squat stance topic, that is actually how I discovered you about 2 weeks ago, or a week ago, whenever that was. And, I found that very interesting. I'd like to talk to you about that today. A lot. That's something that's not commonly addressed a lot of teachers teach this ubiquitous squat stance, feet shoulder width apart, toes pointing forward.
Yeah, right.
But share some insight on that. Your work basically has demonstrated that everybody's hip anatomy is different, and there is no ubiquitous squat stance for everybody. Everybody needs to squat differently, and everybody has different stances that are optimal for them, right?
Sure. Yeah, exactly. And so the way it kind of came about, the title, the best kept secret, right? It's really not a secret because in any medical school, physical therapy program, chiropractic school, we are taught extensively about hip anteversion and retroversion. And I remember sitting in biomechanics class, and the way they always show this picture when they describe it in any sort of textbook, it doesn't click the way that it's illustrated. But the concept is taught, just they don't connect it with squatting because they don't really, go into that. So my wife, this is kind of how it led me to write the article. My wife is half Filipino, and she can squat like nobody's business, like just no problem. Any position, she can just get amazing depth. Mm-hmm. And she's been to the CrossFit Regional several years in a row. And another gal that we work out with, she, I don't know what her ethnic background is, but I think she's Western European, and she's also a pretty high performing athlete. And their squats look so different. And the other gal was always trying to get a narrow, deep squat like my wife's. And I'm looking at her like, it's not going to happen because you can watch the way her hips track when she descends into the squat, and her knees want to go out because that's the position where the socket will allow the greatest depth for her, where she can express the most hip flexion. I'm like, man, I need to write an article about this. Yes. Like people need to know about this because she was trying to force herself into this little box, and that can lead to people getting hip impingement and those types of things over time. And so I just went to the internet and, can I find some pictures of actual bones? And I found them on this guy's website, Paul Grilly. He's a yoga guy. And mm-hmm. I emailed him, and he said I could use the pictures for an article. And so I wrote that kind of very bare bones article. It wasn't really technical. It just kind of got to the, get some ideas flowing for people and show some pictures and kind of connect the dots between squatting in an athletic kind of environment and then the hip pictures. And then it got, the traffic that I got was pretty incredible. I'd never expected that to happen. So. Mm-hmm.
And then you kind of built upon that and elaborated with that video that you made, right?
Sure. Yeah. So I originally wrote the article 15 months ago on my site. And then the John Goodman of the Personal Trainer Development Center wanted to repost it on their site. And in conjunction with that, we thought, hey, you know what? The biggest question that keeps coming up is, what do you do with the information?
Yes.
And, the information is one piece of the puzzle. Like it's not, your hips are this way, so that means X, Y, Z. It's like you got to use it in context of the move, because that person might have different like bones, their ankles might move differently, et cetera. So we made the video as a follow-up to, hey, how can you use this information? How do you put it into context? Mm-hmm. Because the biggest criticism and one thing I look back in retrospect about the article is people keep telling me that people are using it as an excuse to not like work on their squat form.
I see.
And I think that that is an unfortunate consequence of the article, is that people will use it as sort of a cop-out. Yes. And that was never the intention, of course. But the idea would be, that the hip is a ball and socket joint. So if you can put it into a position that allows the greatest amount of range of motion, so you don't have to round your back in the squat, and you would want that range of motion in the ball and socket versus in the spine.
Yes.
And so we try to find our position that allows greatest depth, and then that should be the position that we mobilize, work on, etc.
And in your video, you show like assessment techniques that one can do on oneself to find their best stance, right?
Sure. And I mean, what you could do too is just put a camera and videotape yourself from the side, try different widths of squatting and see which one allows you the greatest depth.
Yes.
The things I showed in the video just kind of, gave you a little bit more information, but you could just skip all that, and whichever one gives you the greatest depth without the spine rounding, and the knees track properly over the middle to the outside of the foot, and the heels stay down.
Yeah. Yeah. So
that's what we're going after.
That's super interesting, man. I've just been working with a physical therapist recently, just to kind of optimize my biomechanics and
Mhm.
kind of work on some mobility issues. And what I found is I cannot get into an overhead squat position with my feet with my feet shoulder width. My whole spine goes into flexion. I just like fall forward like a roly poly. And I was trying to work on my like extension, keeping my
Mhm.
like thoracic spine extended by doing these like banded exercises with keeping my feet in that shoulder width stance, and I just couldn't do it. Like it didn't matter how much I tried to like reprogram my nervous system, create
Sure.
new movement patterns. I just couldn't do it. My whole spine would just round forward. And then my PT was like, try taking a wider stance and externally rotating your feet a little bit. I did that,
Mhm.
and I was able to keep my spine almost like perfectly vertical. Um,
Right.
which
Yeah.
is it's interesting though because I'm sure you know of like Kelly Starrett, right? You know that guy,
Sure. Sure.
of
Of
course.
course.
He's
Yeah.
always talking about how the feet need to be parallel in order to generate torque,
Uh-huh.
right? So if you're externally rotated, then you're kind of missing that ability to generate that torque through the legs, right?
Sure. And I think that that has been a controversial topic as well.
Mm,
I don't know if you saw they put a panel together of different people and discussed that on the what they call it CrossFit Offline
all right.
episode.
Mm-hmm.
I think that and one thing that's common in the shoulder, right? The other main ball and socket joint is imagine that you had this range of shoulder internal and external rotation.
Mm-hmm.
Now, some people it might think of it like a flashlight. For some people, it's going to shine this way. For other
Yes.
people, it might shine this way.
Mm-hmm.
Other people, it might go this way. And that could be similar in the hip. So for some people, they're neutral of when they're centrated in their hip joint, their feet might be pointed out 5 degrees. And so if you internally rotate them to have their feet straight,
Mm.
you're either gonna really twist and internally rotate the knee, or you're gonna internally rotate the hip. And for most people, when you internally rotate the hip, you decrease the amount of hip flexion.
Yes.
And so that's why someone like you, perhaps, if you bring your feet too close in, you're internally rotating your hip, you just run out of room.
Mm-hmm.
And if you can externally rotate a little bit, as long as the knees don't drop in, I think that's one problem, right? If you say you can go wider and your feet can point out a little bit, you got to make sure and be a little bit more diligent that the knees don't drop in. So I think when Kelly Starrett talks about the feet being directly forward, I think that spares the knee more. Like it decreases how the potential for the knee to drop in. So I get why
Yeah.
people recommend that.
Mm-hmm.
But I think, like in your example, if you squat super narrow and it makes your spine round, I would rather have you go wider and make sure that your knees contract properly and then your back doesn't round, because maybe it
Yes.
was never, what if it was never a corrective exercise problem? It was a stance problem. And you could spend 5 years trying to correct something and it'll never get corrected.
Mm-hmm.
Just like, I can't bend my finger so far back, it ends at some point.
Yes.
So
Mm-hmm. Yeah.
I think we just have to take that into consideration. And Stu McGill, that's actually I think it was either the first time I really kind of put together that information was either from listening to Stu McGill talk, or it was Shirley Sarman's book, Movement Impairment Syndromes, where I really was like, that really matters. That
Dude.
really matters.
Check this out. I'm literally resting my laptop on top of that book right now.
Right. So in that book, for example, in the hip section, she talks substantially about hip retroversion and antiversion,
Mm-hmm.
and how it can affect a lot of things. So
Yeah.
that's a fantastic book. If
It
the
is.
listeners do not have that, that is
Yes.
a gold mine. That is a gold mine.
Indeed, it is. Yeah, so key takeaway there, people, is everybody's squat stance. There is no ubiquitous optimal squat stance. Everybody needs to take a different stance that's optimal for them. And some key points to be looking at is if you're taking that squat stance, are you able to achieve a nice optimal depth in squat without that knee valgus, without those knees knocking together, and without your spine rounding in? If those things are happening, then you need to start addressing your stance and maybe some mobility issues. But like me, I was constantly trying to force these optimal mechanics without addressing my base of support, and it just wasn't possible. Like Ryan said, I just ran out of room, and then eventually I would just round forward. It's like there wasn't anything I can do other than address my stance. that was going to stop those things. So that's a takeaway there. Ryan, I was looking at your YouTube channel the other day,
Hmm.
and I saw one of your videos entitled "The Tight Hip Flexor Myth" or something like that. So I've made videos on how to release tight hip flexors before, but
Sure.
in your video, if I remember correctly, you were saying that it's not so much of a shortness issue as it is an overactivity, like neurological issue, right?
Sure. Um, to first address the self-release stuff, I actually did a video with I don't know if you saw the video I did with a surgeon.
No,
The abdominal
yes,
surgeon.
yeah. I wanted
Yeah.
to talk to you about that too because
Okay, we'll talk about that.
I've also made videos about how to release the psoas using
Sure.
pressure techniques in there, and
Yeah.
I thought that video was very interesting.
So we'll talk about that in a minute then.
Yeah.
Um, so the idea would be, the first thing we have to think about is when we talk about a muscle being short or tight, is it the muscle itself is anatomically short? Or are we saying that there is scar tissue preventing the full excursion of the muscle? Or are we saying that there is too much tone in the muscle and it cannot relax to lengthen?
Mm-hmm.
And I think we are so quick to think that the muscle itself needs to lengthen or there is scar tissue that needs to lengthen. And I think we underappreciate how frequently the muscle needs to know how to relax and lengthen. And so, hey, if we do soft tissue work on an area and we get improvement in range of motion quickly, the chances that we're actually breaking something apart to make that happen is very unlikely, just because of how quickly it changes, because the scar tissue cannot remodel that quickly. And scar tissue is extremely tough material. For example, I think I mentioned earlier, my wife's a nurse and she works in the operating room, and she tells me, and I've talked to some surgeons about this too, that the scar tissue when they dissect through to get somewhere they need to be is unbelievably tough.
Yeah.
And so it's just hard to conceptualize that we can just kind of break it apart so easily. Like it just melts away, because if it melted away, then every time you jumped or ran or something, all the connective tissue would just disintegrate, because there's so much more force going through, like say you're doing a plyometric, there's so much more force going through the tissue than there is when you put a roller on it.
Yeah.
And so if the roller could theoretically break something up, then your connective tissue would just explode. Anyway, so the point with that video is, hey, I've seen so many quote unquote tight hip flexors, especially more commonly in females than males, and it usually is that their postural position is in one where they are basically holding the hip flexors in a long position, like they're almost resting on the length of it, and so it becomes tight feeling, because tightness is just a perception.
Yes.
So tightness can be fatigue. Tightness can be, more than just shortness. And so in these people, I find that they stand in a specific way. Typically, they lean back on their heels and then they push their hips forward. So they're constantly like in hip extension. And so the hip flexors are always being tugged on while they're standing. And so they complain of this tightness in the front of their hip, but it's really just, I think, more of an overuse issue. And so what I showed in the video was, hey, can you stabilize the spine and the pelvis with the ribs using the kind of ab muscles, right? So you're basically locking your rib cage onto your pelvis, and then seeing if you can flex and extend your hip without your spine moving, because that means you can basically let that muscle lengthen and shorten without the spine being tugged on.
Yes.
And so I find a lot of times in those people who have that chronic hip flexor tightness, they have a weakness in the anterior chain, and every time they extend their hip, it basically pulls their lumbar spine into extension. Mm-hmm. And maybe their hip flexor is doing a little bit more of the spinal stabilization versus some of the other muscles, and so it gets overused in that way.
Yeah.
Also, so there's more than, especially when these people tell me that I've been stretching my hip flexors for a year and they're still tight.
Mm-hmm. Yeah.
If you stretched it for a year and it still feels tight, there's something else going on besides just a stretching deficiency. Mm-hmm. And so that's kind of what I was talking about with that. I'm not going to say that there's never a short or hip flexor or a scarred hip flexor. I just think it's in a smaller proportion than the kind of, there's too much tone or too much contraction or overusage of the hip flexor.
Mm-hmm. Yeah. Yeah, that's an interesting take. So you think that most of the benefit that people derive from pressure techniques on like the TFL is mostly affecting like the neural drive to it rather than the,
Exactly.
yeah.
Exactly. Because when someone rolls something and it feels immediately better, and then the next day it's tight again, there was no way it was scar tissue, because if it got loose and then it retightened, that scar tissue is not going to form overnight again in the same quantity. So when people do that, they roll and the next day and then it feels better, and then later it feels tight again. They roll, and etc. It's more of a neurologic thing,
Yes.
than it is you're breaking things apart.
Yeah. Yeah. That makes
Which kind of goes against the grain, right? I mean, because there's so many techniques out there about breaking stuff up.
Yeah.
I don't think those techniques are ineffective. I think the mechanism by which they work is just different than what we have assumed, but that doesn't mean they're not effective.
Yeah, and there's a good chance that those things are happening synergistically, right? You might be getting a little bit more length being created in conjunction with that decreased neural drive from doing these pressure techniques, and that might be where the instantaneous like benefits are being derived from. Right?
Sure, and we could never prove it. I mean, that's the
Exactly.
thing, right?
Yes.
We can never really prove that.
Yes.
The only way you could prove it, right? You'd have to take a tissue biopsy and see how much scar tissue's in there, roll it out, and then take another biopsy. And like, who's going to do that?
Yeah.
But I think they have. Who was I talking to? I was talking to somebody about this, and they were referencing a study where someone who was like kept in a cast, and they had basically contractured their biceps. They took samples as it lengthened, and there was no actual like tissue change, so it was all neural drive.
Let's see.
I don't spend the whole day reading research though, so I can't cite any studies on that.
Got it. But coming back into what we started to touch on, but then brought our attention back to the hip flexors. You
Sure.
made a video with that general. She was a general surgeon, right?
Yes.
About basically the dangers and the dangers like associated with trying to release the psoas using pressure techniques, trying to go through like the abdominal wall, right?
Right. Yeah.
So that video is, I mean, that's a very controversial thing too, right? Because Kelly Starrett has all these techniques of how to use, like a softball with a kettlebell and release, basically to get into the psoas and release that. There are a lot of people that say that the abdominal wall is so thick in itself, not to mention all of the viscera that's underneath it, that like you just have all this shit in the way. It's like you're not gonna be able to actually even penetrate in and reach the psoas, right? That's basically the gist of that video.
That is the gist of the video.
Yeah,
My wife's filling up a cup of water.
got it.
This microphone picks up everything.
Yeah. So yeah, the gist
Right.
of the video was that not only can you not get in there, but it also could be, putting you in danger because you have to kind of smash the intestines in order to get in there, right?
Yeah. So for those who haven't watched the video, it's an excellent video, and the gal's anatomical knowledge, right, is like unmatched. Who knows internal anatomy as well as a surgeon.
Yeah.
So it's really cool to listen to her talk about it. Just such an in-depth knowledge. So yeah, someone sent me a video. I can't remember who was in the video, but it was a hip flexor release technique basically, and they were doing the release really high up in the abdomen, and I just think there's a misconception that there's like skin, your abs, and then your psoas just hanging out right there to be touched and manipulated. But in chiropractic school, we spend 9 months dissecting a body, and 3 of those months were spent dissecting basically the internal or the organs or through the abdominal cavity. And I developed such an appreciation for how much stuff is in the abdomen. And it's very full in there, and not everything kind of slides out of the way necessarily. I think there are certain areas that are probably more accessible in the hip flexor. So, in the kind of more around the top of the pelvis, I think you can access the hip flexors more, but I don't think you can access it really high up in the lumbar spine, like where it attaches, because it's below so many organs.
Are you talking about like the psoas iliacus like junction?
Right. Yeah. So if you go farther down, like, maybe towards the insertion or a little bit above the insertion on the femur, you might be able to, you could probably affect it there.
Yeah.
Even doing, because people will say like, hey, but when I do this release technique, I feel improvement. It's hard to argue with results.
Yes.
But again, what is the explanation? When we do that, maybe we're applying some deep pressure to the psoas, it's not going to be direct. And I think that there's a conception or a perception out there that we're kind of like going into the hip flexor and we're like pulling it apart and tweezing it apart. I think that we may be applying some general pressure to it, and we're getting some sort of neurologic response from that, just like you would any other muscle. But again, now we're going through layers of organs, which may or may not be the best thing.
That's a tough one though, man. Because what are people supposed to do? Because what you were talking about earlier with that test where you put the band underneath your back, I think that a lot of that lumbar extension, when you're like lowering your legs back into extension or your hips back into extension, that's coming from like the psoas, right? Because they attach on the transverse processes of the lumbar spine, right? So, like, if somebody knows that they have really tight psoas muscles, then if they're not able to, get in there with pressure techniques, then do you know any like alternatives, or do you have like stretches for that you like?
I don't think there's anything wrong with doing very light pressure, if that helps. I think the problem is people do it so aggressively, not realizing there's like some somewhat sensitive structures in there. And to me, that's the problem. So
just like recklessly smashing a softball in there.
I don't think it's a good idea necessarily to aggressively push things in there, but that doesn't mean that lighter technique cannot be effective. But what I typically do for that person is, if I can get them stronger in their anterior chain, or if you want to talk about anatomy trains, their superficial front line, and I can create more spinal stability there, then can I get the psoas or the hip flexors to relax? That's how I'm thinking about it. Rather than what can I do to the psoas to make it relax? It's what can I do to the body to make the psoas relax. And so if I think about that test that I did, a lot of times people's tight hip flexors will go away if they get really strong in planking. If they can get really strong in planking and change their pelvic position in their standing posture or walking posture, a lot of times that tightness goes away.
Yes.
And I didn't need to roll it necessarily. But it's, that's just a different perspective, because there are people who do get some temporary relief from that. I don't like temporary relief.
Yes.
I want it because there's so many people out there who don't need to roll out their hip flexors. Why does that person need to? That's the problem I'm trying to figure out, rather than how to best roll it. How do I get them so they don't need to roll it?
Yeah, because when you're rolling it, you're treating the symptom, right? Which is the overactivity, shortness, tightness, whatever it is, the dysfunction. That's just a symptom, and you're trying to address it at a deeper root level, right?
Yeah,
the cause.
Exactly.
To fix it for good. Yes.
Right, exactly. Because I want to know why things are happening, not just that they're happening. So if someone has tightness in XYZ, I think we should address the tightness because it's going to make them more comfortable, but we have to figure out why it's happening.
Yes.
Yeah.
Yeah. I try to take the same approach with my clients. Everybody should take that approach, right?
Agreed. That doesn't mean that rolling things out isn't something to do. It just means it's part of the puzzle. It's not necessarily the only thing.
Yeah. Have you ever heard of Liz Koch?
I've heard the name. I can't remember why though.
She wrote a book called The psoas Book.
Oh, I've read that.
Yeah. So she's got some interesting techniques in there. I present those as alternatives to pressure techniques in the video that I made about how to release the iliopsoas. But yeah, I don't know. That's just that's a tough muscle to get to, man. It's just because of what we just talked about.
Well, and so I'll say two things real quick. I was teaching a class a couple months ago, and someone, because I talk about this in my class, and we talk about the internal anatomy, and someone was saying that someone from their gym actually went to the emergency room after aggressively pushing into their abdomen. Nothing was wrong necessarily, but there was a bunch of nausea and things like that led them to need medical care. And then a guy in Australia who runs the Physio Detective, which is his website and stuff. He also wrote an article about this a couple months ago, I think, and said that someone actually had a ruptured appendix and they were rolling it because they had abdominal pain. And, we just need to be aware that there can be other causes of pain and discomfort that come from that region besides just the muscles, because there's a lot of innervated structures.
Yeah, like you said in the video with the surgeon too, you can afford to be a little bit more reckless per se with your pressure techniques on the extremities where where they're not surrounded with so many organs and other structures that are easily damaged and not movable, right? Because you can smash your like rectus femoris all day and not worry about damaging your your internal organs, right?
Sure, right, yeah.
So
And it's
yeah,
not like the internal organs are like you're going to touch them and they're going to rupture. So
yes.
I don't want people to have the perception that they're this very, very fragile person. But
Hmm.
yeah, I mean, if you go too hard in there, it might not be the best idea.
It is kind of common sense, though, right? It's like you don't want to be jamming anything in there, especially if it's causing you, undue pain. So I gotta like wrap it up here in a second, man.
Okay,
But why don't you? There's a couple things I want to ask you before
sure.
we finish up here.
Hmm.
So this one's kind of gonna this is gonna be like a blanket statement that I want you to make. But
Okay.
if you had to make a list of 5 like corrective exercises, being mobilization, soft tissue work, strengthening, activation exercises, 5 exercises or 5 corrective exercises to address the most common dysfunctions that you see in your athletes and your patients, what would they be? Could you just give like a list of like catch-all exercises like that?
Sure.
All right.
I think cervical spine retraction
Mm.
is a big one. For a lot of people who have shoulder and neck complaints,
Yes.
they lack retraction of the cervical spine.
That forward head carriage.
Right. And so they can develop stiffness against cervical spine retraction and extension, especially their upper back.
Yeah, they go forward into kyphosis.
Sure. And then they have shoulder impingement and things like that because, they're basically changing the mechanics of the upper quarter. So that would be one.
So you hear that, people? Pull your head back. Keep your head on top of your spine. Right?
Yeah. I mean, not maximally.
Yes.
That is something that, if I instruct someone to do that, I have to tell them, do it, but don't live your life pulled back as hard as you can, because you're going to get some other issues from that. That's such a hard question because, and I'm sure you know this too, like when you do movement assessment, every single individual has different things. And so what I say right now for one person will be excellent, but for another person, it could be the worst thing for them to do. Like if I say, hey, people need to stretch their shoulders, but then a female with hypermobile shoulders, that would be the worst thing that she could do.
Mm-hmm.
So it's
hard. I know it's a hard one, man.
It's hard to say. I think the best approach is, if you think about the joint by joint approach. Are you familiar with the joint by joint approach?
No.
So the joint by joint approach, which I think was first kind of described by Mike Boyle and Gray Cook, is that there's alternating the segments in the body, or the joints in the body alternate in what they need. Either they need more mobility or they need more control or stability. And so I think if someone follows the joint by joint approach in terms of what they need to do, that would be the best approach. Generally, blanket statement. And so that would be like the hip needs more mobility, the low back needs more control and strength, the upper back typically needs more mobility, the middle of the neck needs more control, the upper neck might need a little bit more mobility, the shoulder needs mobility, the shoulder blade needs good control. So typically those are the rules that I would follow generally if I was programming for somebody without knowing anything about them.
Yeah.
So it'd be stretch the hip, strengthen the low back, mobilize the upper back, do some control training for the shoulder blade. That's the kind of general approach. So it's hard for me to say what those 5 would be.
Yeah.
However,
I can tell you're big on opening up the thoracic spine, because I've watched a lot of your like warm up videos, and a lot of them like include like mobilizing the T spine.
Sure, right. And I think that a lot of shoulder mobility issues or a decrease in shoulder range of motion is either a decrease in scapular motion or a decrease in upper back motion.
Yes.
Versus the shoulder joint itself. So we have to look at all those because they all work together when you go like overhead lift or anything. And so we have to look at all of those. And so I don't know that I can give you, because for one person it's going to be their shoulder blade doesn't move enough, and the other person's their upper back, and the other person's their shoulder joint.
No, I get it, man. That was not even a good question.
It is a good question, because I think that thinking about that, there may not be a perfect thing for every person.
Yes.
Is an important point to make.
Mm-hmm.
But when I do make a general thing, I do follow the joint by joint approach. But that will vary from person to person because some people have a ton of ankle range of motion. They have a ton. And in a joint by joint, the ankle is something that we want a lot of motion in. But if someone has a ton of motion there, they need to be able to control it. So the person who's hypermobile in that ankle, if there is such a thing, they need to be able to control it, whereas someone else may need to mobilize it.
Yes.
And so that's because I had a guy yesterday. He had unbelievable ankle mobility, and I asked him if he ever stretches his calves or ankles, and he said, I never do it. And he had 6 inches of ankle dorsiflexion in a lunge test on both sides, and he never stretches his ankles.
Yeah.
Yeah. So
it's important too. I just made a video about this to always follow mobilizations with activation strengthening, right? Because
yes,
a lot of people don't even emphasize that at all. They just tell people how to mobilize a joint, but they don't emphasize the importance of training your neuromuscular system to use that new range of motion that the mobilization gave you. Right?
Yes, that is so unbelievably important.
Yes,
and then
if you take not many people are talking about that. Everybody's talking about mobilizations. I don't hear very many people emphasizing the importance of activation following, which is everything, right? They have to go hand in hand.
They do have to go hand in hand. So if you improve range of motion, you'll get a temporary improvement, but the brain has a map of every joint in the body, right? Just call that proprioception, whatever you want to call it. If you open up and sort of start to map out this new area, and then you don't learn how to control it, kind of explore through there, then potentially you're traveling in uncharted territories. And so when someone mobilizes something aggressively and then immediately goes and works out, that makes me a little bit nervous.
Yeah. That can cause a predisposition for injury, right? If their neuromuscular system doesn't know how to function in that new passive range of motion that the mobilization gave them, then they don't know how to move in it, right? They're all messed up.
Yep. And then what they're doing potentially is putting the passive structures at risk of being overstressed. So if you got rid of all the muscle tension around the shoulder, for example, and then you went and you snatched, and you don't have good control muscularly, then you could kind of rely on some passive elements to the shoulder, like labrum, et cetera, that could cause some wear and tear over time.
Yes.
Yeah.
Yeah, for sure.
So maybe that's a blanket statement, right? If you're going to do mobility, do some sort of control drill and then do a functional movement.
Yes. Some sort of integrated
There's the
thing.
There's the blanket.
Yeah. That's a good system, man. Mobilize, activate, and then integrate.
Right. So, yeah, exactly. And so if you watch any of our last year I did a video a day for 30 days. And in those videos, you can kind of see that that's what we did. We did some sort of either soft tissue preparation and then a mobility drill and then some sort of motor control drill and then used it either in a squat or a jerk or a snatch or something like that.
For sure.
And then we did cycles of that.
Yeah.
So.
Cool. Awesome, man. Well, I got to get going here, Ryan, but
all right.
I would love to talk to you again sometime. I didn't really get to run through everything that...
it always takes longer, Yes.
It
always takes longer.
Yeah, and you and we could probably talk about things like this all day. I mean, literally, the topics are unlimited. But where can people reach you at, Ryan? What's all your social media information and your website and everything? I'll include a link in the description down below too, so everybody can find that. Yeah,
so the website is themovementfix.com. So the main kind of outlets I have is that Twitter. The Twitter handle is The Movement Fix. Instagram is The Movement Fix. And then I also post a new video every Monday. At least I'm doing that for 2015. So it's just youtube.com/The Movement Fix. And then all my contact information is on the website as well.
Cool. All right. So like I said, everybody, I'll include that in the link down below. I'll include a bunch of links to all of those things that Ryan just mentioned. Other than that, Ryan, thanks for coming on today, man.
Sure.
Had a great time talking to you. And,
thanks for having me on. I appreciate it.
For sure. We'll have to do it again.
All right. Sounds good.
Bye-bye.
Take care.
If you enjoyed that video, then give it a like. And if you haven't subscribed to my channel, go ahead and do that right over here. Also, I'm a little bit more active on Instagram and Facebook these days. So go there, follow me on Instagram, and give me a like on Facebook as well. I'll include a link to both of those in the description down below. And lastly, if there's anybody that you would like to see me have on the video cast, then leave me a comment down below. I'd really like to have your feedback on that because I'm always searching for new people and ideas in regards to the video cast that I've been doing. So if there's somebody that you want to see me interview in particular, then leave me a comment down below. Other than that, I'll see you next time.